Hello, everybody. Oh, yeah, there we go. We're just about ready to start the Seizure Treatments seminar. And most of us have probably been here already this morning, so we know that this is Dr. Ron Thibert from Massachusetts General and has such great experience with treating Angelman and seizures and sleep. So we're excited to hear from him today as he presents possible sleep treatments. Dr. Thibert has a meeting to get to at 12:35, so built into his session, he has time for you to ask questions, but we're going to have to make sure we finish at 12:35 so he can sneak out for his next meeting, okay? Thanks very much. Here he is. Please welcome Dr. Ron Thibert.
Thanks. So I'm impressed that so many of you have been okay to listen to me for 3 hours. Hopefully it's not too painful, but so we talked about seizures last hour, and this one's going to be about seizure treatments. I know some questions came up, and we talked a little bit about some things, but this one's really just going to focus on the treatment of seizures. And so, so for those of you here, I have this first slide, but it's a little more relevant to this one. As you know, the UBE3A gene kind of in the middle there, that's the main causative gene for Angelman syndrome, but also the GABA receptor genes, the ones, the GABRB, whatever numbers, there's three different numbers. Those are the genes that, they help code for things that make receptors for GABA, which is the main chemical in the brain that helps kind of quiet things down. And so with seizures, in everybody's brain, we have chemicals that excite things and chemicals that quiet things down. And for those of us that don't have seizures, those work well together. For those of us that do have seizures, one of them's usually off, either too much excitement, too much bringing down. And so with if your GABA is abnormal and it's not working right, you're going to have less stuff that calms you down, and then that's going to lead to more seizures. So I think that's one of the big, even though the UBE3A gene is the big thing, and that's probably the main reason behind the seizures, but those genes I think add to it. So the manifestations of Angelman, for those of you who've been here all morning, you've heard it twice, but for those of you who aren't, I'll go one more time. It's mainly neurological and psychological. UBE3A, which is the main gene, is abnormally expressed in the brain. So that's why you don't have heart problems, lung problems, kidney problems. But it affects the brain. So what we see is epilepsy. We see sleep disturbance. We see developmental delays. We see movement disorders, anxiety and difficult behaviors, GI dysfunction, which I think is partly the GI tract, but mainly it's the nerves going to the GI system, and also behavioral stuff that go into worsening GI problems, and then orthopedic and ophthalmologic issues. So we typically have kids at least for a one-time visit see an ophthalmologist and orthopedist, just because the nerves that control the eyes, and then with abnormal development and motor skills, it can lead to problems with your spine, your hips, your ankles, that kind of stuff. So that's why in our clinic at Mass General, based on what we know biologically and then what we see clinically, these are the folks that we really need to help get kids as healthy as we can. So neurology and epilepsy, genetics, psychiatry, neuropsychology, sleep medicine, GI, and then consults as needed to the other folks in ortho and ophthalmology. And then we opened in 2008. Officially, we kind of partnered with, we'd been working with the foundation the whole time, but kind of had that official opening and party in 2012. And then we see families both at Mass General and the Lurie Center, which is a good place where we see our adults because we have an adult program built in. And we've seen so far 170 families from, I think we counted like 24 or 26 states, and as well as a handful from Canada, a couple from South America, and one little guy from Russia that came to see us. And the age range is 9 months to about 42 years. And then that's the clinic. No, I'm just kidding. But that is Mass General. And then, so back to seizures. We'll just do one slide because we just did a whole talk. But epilepsy and Angelman syndrome is a generalized epilepsy. We talked about focal versus generalized. You can have focal seizures, but in general, it's a generalized epilepsy and has to be treated like a generalized epilepsy. And the main seizure types are tonic-clonic, atypical absence, atonic, myoclonic. Well, those are just types in general, but tonic seizures and spasms happen, but they're rare. Those are the ones that are kind of harder to treat, come along with a kind of a worse developmental prognosis, but so they are seen in some kids, but it's rare. And the question is, do those kids have something else? We've seen kids with Angelman syndrome and rare metabolic disorders. We may have someone who has 2 genetic disorders now. So for these kids that have Angelman, that the rare cases of spasms, the rare cases of tonic seizures, the question always is, well, is there something else going on? Because even though it's kind of sucks, you can have 2 things. And so whenever we see something that's not really typical, we always say, well, let's check it with the geneticist. Maybe there's something else going on. So treatment of seizures. So kind of going back to the study that I talked about earlier, we did a seizure survey through the foundation in 2007, I think we did it, but we published it in 2009. 461 individuals with Angelman syndrome. We got responses from families, 60% having more than one seizure type, most with generalized seizures, but 30% did have focal seizures as well as part of the syndrome. And so these are I think I talk about them all individually. Hang on, yep. So I won't go into detail here. But when you look at seizure medicines, you think about 2 categories: broad spectrum seizure medicines, and then what we call the non-broad spectrum. They don't have a name, but I call them non-broad spectrum, or focal generalized tonic-clonic. So medicines such as phenobarbital, phenytoin or dilantin, carbamazepine, which is Tegretol, oxcarbazepine, which is Trileptal, gabapentin. I actually use gabapentin in kids with Angelman, but not for seizures. But technically, it's not a broad spectrum. And then pregabalin, which no one really uses because it's expensive and doesn't do much. But if you look at the older medicines, the dilantins, the phenobarbs, the Tegretols, those are, and the Trileptal, which is a good newer medicine. But those are medicines that are meant to treat focal seizures, and they'll treat kids with focal seizures. They'll treat the generalized, the tonic-clonics that can come from the focal seizures, but they'll worsen head drops, they'll worsen absence, they can worsen myoclonus. So those are medicines that we really try to avoid. The exception being status. Someone has a seizure that lasts half an hour, they come to the hospital, they get loaded with phenobarb, they get loaded with dilantin, and because it is a prolonged tonic-clonic seizure, they do work and they do stop the seizure. So those are medicines that we do use in status, but they're not ones that are good for everyday use. So you really can make things worse with the wrong medicines. And we've had kids that have come on Trileptal that have been in non-convulsive status and that have fixed the non-convulsive status just by stopping the Trileptal. So you really have to be careful. So you have to be on the right seizure medicines, I guess, is the take-home point. So the medicines that are the right medicines are the ones on the left, and they all have their pluses and minuses, but they're all broad spectrum seizure medicines, and we'll go through them one by one. So I won't get into the whole detail here. When we looked at that survey back in 2007, we looked at different like who was on what medicines, and what we found was that most people were on Depakote, that's the purple one, or valproic acid. The next one over is clonazepam or Klonopin, and then actually that yellow line is phenobarb, which is a medicine that really doesn't help too much as far as we know in Angelman syndrome. The next one is Topamax or Topiramate, and then the next one over is carbamazepine. So there's somewhere I think it was 15% of kids were on carbamazepine or Tegretol, which we know kind of worsens things. And what we found, not surprisingly, the light purple lines are those who had really good seizure control, so 90% or more seizure control. The red ones are meds that made things worse. So if you look at way over on the left, that's Depakote and Klonopin. Way over on the right is Keppra. That big giant red line with really almost no purple line, that's Tegretol. So 60-70% of people it made things worse. Pretty much nobody it helped. So kind of what we found was what we expected, was that you go on the wrong medicines and things don't get better. And then what we did was we kind of went through. Epilepsy is called refractory when 2 or more medicines don't work. So you try a medicine, it doesn't quite work. You try a second medicine, it doesn't quite work. You move to your third treatment. So that's officially refractory epilepsy is a definition. What we found was that 77% of kids in this study were refractory, so the first 2 medicines didn't really do the job for them. And as I'll talk later, that seemed really high. It didn't seem like what we see in clinic. We usually have much better luck than that. But looking back, you think, well, if you have a bunch of kids on Tegretol and phenobarbital, of course, they're not going to get better. So in the study, that's what we found, and that's what's out there in the data. And I think people cite it and reference it, and that's what we found. But in reality, if you use the right medicines, I think the numbers are much better. So I'll go through each medicine individually. Sorry, when you talk too much, you get thirsty. So the first of the broad spectrum. So before 1978, all you had was phenobarbital and Dilantin and the benzos and Zerontin. So it was this was the first big broad spectrum that came out. And I know I've been kind of talking bad about Depakote, but it's not that bad a medicine. It's just in Angelman syndrome it can cause more side effects. But as I was saying to some folks earlier, it's the data I showed before, and I'll show again later, about 2/3 of kids had a lot of side effects, but some kids do fine on it. So it's not like it's a wrong choice. It does work. It just tends to have more side effects. We try others first. But it came out in 1978, and it's kind of a messier drug than the newer ones. You can get a lot of side effects just in general, not Angelman type side effects, but you can get fatigue, sedation, weight gain is a biggie. 10 to 30 pounds is not uncommon. Tremor and imbalance are side effects. So already thinking about it, you have kids with Angelman syndrome who have tremor and imbalance. You start a drug that causes tremor and imbalance. This is kind of what you end up with. For girls, earlier today I said mostly in girls, but always in girls, irregular menses. And then you can get, in some kids you can get what they call polycystic ovarian syndrome. So the girls on Depakote tend to have very irregular periods and sometimes very heavy. They can be long, they can be short, they can come. It just really kind of messes with things. And polycystic ovarian syndrome is when they really gain weight and get kind of hairy. And so my teenage girls I never put on Depakote, but there's just things that are there. So we have to check blood with Depakote pretty frequently. Liver tests, blood counts. If things aren't going well, we check ammonia levels. They can be kind of scary. Amylase lipase occasionally. It's not common, but you can get pancreatitis. It can lower carnitine levels. Actually, it does lower carnitine levels. So if you're not supplementing with carnitine on Depakote, you can get low carnitine and then decreased energy, and that can worsen seizures. So it's a lot of monitoring and it's a lot of maintenance. The next one is Valproic, which I didn't talk about at all today, and it's probably because we don't use it much. It is a good medicine. It came out in '93, so it was the second broad spectrum that came out. There was Depakote and then nothing for a while, then this one. And they said, this is like Depakote, but you don't have the weight gain, you don't have the hormone stuff, you don't have all the other, it's going to be amazing. And it came out, and in the first year, 20 people died from Valproic. So from bone marrow suppression, from liver failure. So the two things, one is that it was all adults. There were no kids that died. The other was that, and this is before my time, I'm not old enough to have been using Valproic in '93, in case you were wondering. But from what we've heard, it was a medicine that was being started and being bumped up fast, and it wasn't known to monitor blood levels that fast. So it actually is being used now. It's not used commonly, but it's used pretty much only by epilepsy specialists. And for kids that don't respond to lots of medicines, it's a medicine that can be used. And honestly, it has, if you don't have bone marrow suppression, liver failure, that kind of thing, it's actually really well tolerated. It actually doesn't have that many side effects. So for kids that don't have those issues, it can work, but you have to check blood weekly for weeks and then monthly for months. And just because if you lose track of it and you start to get the suppression liver failure, it can be really scary. So it's kind of a last resort medicine, but it is effective. I think it would be useful in Angelman syndrome. I haven't used it in any kids with Angelman, but that's, if you ever hear about it, someone asks, it is a medicine that would be an option, but you have to be really careful with it. You have to have someone that really knows how to use it, prescribing it. The next two are very similar, so I'll kind of put them together. So Zonisamide or Zonegran came out in Japan first, and then in the U.S. a little bit later. Sorry. One of the fun things about Zonegran is it has a long half-life, so you can give it once a day, which is kind of nice for some kids that don't like medicine. So most kids I have on Zonegran, it's just once at night, which is kind of nice. The side effects to watch for are so acidosis is one, and it's not common, but you don't want to miss it. So our blood is kind of balanced acid base, and Zonegran is one of the medicines that can decrease that balance, so it can make you more acidic. So if you get acidic, you can have nausea, vomiting, lethargy. You can get really tired. The nice thing though is that unlike some other side effects where you see it and you have to stop the medicine, with acidosis, there's a nice buffer. It's potassium citrate. So we give potassium citrate, the levels come back up and it's fine. So if you do have it, it's not a deal breaker. You can still use the medicine. You just have to buffer it to avoid the side effects. It can have some cognitive slowing. It's one of the medicines. Depakote as well. I forgot to mention that, but the older medicines you see it more. not everybody, but some kids, it can really kind of slow down how they think and learn. Some kids tolerate it fine, but others don't. And rarely you can get kidney stones. So especially if you're acidotic, you're at higher risk for kidney stones. So whenever we have someone on Zonegran and they get, especially if they're nonverbal, they get really cranky. That's always one thing we think about. Like, let's get an ultrasound, look for kidneys. Luckily, we haven't seen any, but it's a thing, and we look for it if we see crabbiness. So we don't need a lot of blood for that. I unless there's symptoms, I usually check yearly, every 6 months the first couple times, then yearly. So it's not like a weekly blood draw or monthly, but just occasionally we'll check, or if things look kind of acidotic-y. So if we see nausea, vomiting, if we see kids tired, we'll check. But otherwise, just kind of yearly monitoring just to stay ahead of it, because if it kind of slowly drifts down and but comes down so slowly that you don't really get it so much affected by it, then you could just be sitting there at big risk for kidney issues and not know it. So it is a medicine. It's definitely a medicine that can work in Angelman syndrome. I do use it, but there's some things to kind of watch for. So Topamax, very similar actually. I didn't mention the drug actions with Depakote, but for Zonegran and for Topamax, the main thing is just not to use them together, because they do the same thing. So you will get acidotic if you use them together, and you can. But typically, drugs that are very similar together, they kind of do the same thing. They don't. Being on 2 versus 1 doesn't really help that much. The side effect I forgot to mention with Depakote, I think it was on there, but I just skipped it, is that it interacts with lots of other drugs. So what Depakote does is it. Let me see. It's late in the morning, so I have to make sure I don't get this backwards. It inhibits liver enzymes, and so other drug levels can rise. So it kind of slows down the enzymes in the liver. So if you're on, say Lamictal is a big one. Say you're on Lamictal and your level is 10. You start Depakote, your Lamictal level could all of a sudden be 20, and so you can start Depakote, have all these med side effects, but it could be the Lamictal because your level shot up on it. So when you have Depakote, you have to really take into consideration what other meds you're on, what their levels are, because things will change. So Topamax, that's not the case, but you don't want to use it with Zonegran. So the same thing, so cognitive slowing. So some people call it Dopamax, which is not fair because it doesn't do that to everybody. But at the higher the dose goes, the more chance, and I think everybody gets a little bit of cognitive slowing on bigger doses. But there's some kids that are really sensitive to it, and so they'll get that slowing at lower doses. So. But it's the same thing. It's one of these things where it's some kids, not every kid. Some kids are on big dose of Topamax, they're doing awesome. It's amazing. But others have that side effect early on. So that's one thing to watch for. The other thing is decreased appetite and weight loss. So sometimes we have kids who are kind of overweight, and especially if it's either a GI thing that's just really hard to fix, and they just keep eating and eating. Some of the kids with UPD just eat a lot. That's just part of it. It's kind of a Prader-Willi type of a thing. So sometimes Topamax is actually a nice option. It kind of decreases their appetite. It kind of takes away a little bit of that food-seeking behavior. So sometimes you can use side effects to your advantage. So in some people, they're kind of little and skinny, and Topamax is just a bad idea. For those who are a little bit overweight and have kind of food issues, whether it's purely biological with the UPD, whether it's GI, whether it's whatever it is, Topamax can actually kind of help with that. And it's an added benefit. It's a migraine medicine, so it's hard to know when kids have migraines. And I'm sure, it's just in X% of the population. So some kids with Angelman, I'm sure, have migraines. So if there's any thought that there's headaches, if there's kids that are kind of holding their heads, looking miserable, it's so hard because they can't say they have a migraine. But if you ever suspect it, and we've had 1 or 2 kids where we have, Topamax can actually be a nice option because it's a migraine medicine on top of a seizure medicine. Now we're getting into some of our more favorite medicines. So Lamictal, or Lamotrigine, came out in the 90s, and again, it has to be used carefully with Depakote. If someone's already on Depakote, you have to start Lamictal at a tiny, tiny dose and go up really slow. It takes months and months to get to a good level with the two together. Side effect-wise, it's one of, if not the best medicine as far as not having a lot of side effects. So cognitive side effects are really low. One thing that does pop up in Angelman syndrome is it can worsen movement disorders. So it can worsen myoclonus, it can worsen tremor. So that's one thing to kind of be careful of. That's the one kind of downside. The other downside is to Lamictal is that you have to go slow. So there's you can get a rash from any drug, but you can get a rash from Lamictal, and if rarely you get this right away. I haven't seen it, luckily, but typically you get the rash, you don't stop the medicine, you keep taking the medicine for days and days. It can become what we call a Stevens-Johnson rash, which is a nasty, blistery, scaly type of rash. So the only thing with Lamictal is sometimes it causes too much anxiety in parents because they watch every second of the day for a rash. So we actually have had to stop it for parental anxiety. But typically it's a true story. But what we see is the rash it's not common. It's 3%, 5%. You see the rash, you stop the medicine, and in the vast majority of kids, the rash just fades and it's no big deal. It's like a penicillin rash. But there is that kind of 1 in 100,000 chance or whatever of just getting the Stevens-Johnson right away. Let's say, luckily I haven't seen it, but it's not zero, but it's really low. But we just go slow. We start a low dose. We go up really slow compared to the other medicines, and just watch closely. And if a rash comes, and we've stopped it for eczema, we've stopped it for chicken pox. So any rash, we just stop it, and then we take a good look and say, okay, that's not a drug rash, and we go back on it. If it is a drug rash, then we stop it. One of the added benefits of Lamictal, similar to Depakote, is it's a mood stabilizer. So if there's mood issues, Lamictal can really be helpful. And in some kids, even though it's not kind of billed as this, it does seem to help anxiety in some people as well. So it can actually be kind of a mood anxiety kind of medicine. So if, again, it's not just looking at the seizures, but you look at what else is going on in the kids. And if it's someone with seizures and maybe migraines, we start Topamax. If it's seizures and maybe some mood issues, some behavior stuff, we might start Lamictal. So you kind of, whenever people say, well, what do you start first? It's like, well, it depends. There's no one thing where it's like, okay, this is number 1, this is number 2, this is number 3. It just depends on each individual kid and what the profile is going to, like the goods and bads of the drug. So like the bad being weight loss, like that can be good for some kids. So same thing with Depakote. Some kids, even though I have said bad things about it, some kids who are super underweight, Depakote increases your appetite, it puts weight on. For little skinny guys, sometimes it can be really helpful to get some weight on. So everything's got its pluses and minuses, and what's a plus for some might be a minus for others. Cognitive slowing is a minus for everybody, so if you see that, we always stop it. So next is Keppra, which is probably the most commonly used seizure medicine in kids everywhere around the world. Well, not around the world, but in countries that we're lucky enough to have lots of medicines. But it's so side effects are pretty uncommon and pretty limited. The big one is behavior. So Keppra rage, Keppra irritability, Keppra anger. Everyone's heard. The psychiatrists hate it. They get mad at me when I start it. But really, even though it gets a bad rap, 20% of people, and big studies have been done, about 20% will get that, and so 80% won't. So even though it's a concern, it's a big deal. You have a 4 out of 5 chance of not having the Keppra anger. So we often start it as a first medicine, and in 4 kids it's great, and 1 kid it's not, and we stop it. If it does cause anger and rage, a couple of tricks. One is to switch to brand name. Not that brand name is better, but it's different. So the generic Keppras are all a little bit different, and so sometimes kids do better on generic, but not brand, vice versa. But if you try generic and it makes them angry, but it helps, you can try switching to brand in maybe a third of kids. That really makes a difference. The other thing is to add vitamin B6 to the mix. So we don't know why that works, but it does, and so in about a third of kids. So sometimes we switch vitamin B6 brand name, the rage goes away. Sometimes it doesn't, and then you stop it because it's not worth being seizure-free if you're angry and kicking everybody all the time. So that's the one. Otherwise, you can sometimes see fatigue, sometimes some coordination issues, sometimes GI issues, but these aren't common. These usually aren't severe. But and like I said before, any medicine can do anything to the brain. When you start a medicine that's meant to affect your brain, it can affect it in strange ways for some kids. But in general, like Lamictal, Keppra is really safe and easy, and for most kids it's great. For some it's not, but that's why there's no clear list like this is number 1, this is number 2, because everybody's a little bit different. So these are the newer ones. So since the seizure study, these are the ones that have come out in the U.S. So Clobazam has been around forever in Canada and in Europe, and so before 2010, we actually used to get it from Canada. So kids in the U.S. that wanted to be on it, that we thought it was really going to help, people would actually pay out of pocket to get it shipped from Vancouver. So insurance didn't cover it, but back when I was starting residency, when I was a med student resident, it was expensive. It was probably hundreds of dollars a month. Towards the end, they had kind of refined things so that it was more like probably under 100 a month or maybe 100 a month. So it was still expensive, but if it worked, people were willing to pay for it, and we were willing to go through Canada to get it. But that coming to the U.S. has been a big game changer. Just having that available, having insurance cover it, having to being able to just give it to kids has been a big help. So I'll talk about that one more, but we use it a ton. And I think I have slides on all of them, so I'm just going to kind of skip through. So Banzel or Rufinamide came out in 2009, and it actually, so most drugs when they come out, when the drug companies do their studies and have them, it's always add-on therapy for focal seizures in adults, because that's what's easiest, that's what's cheapest, that's what comes out. And so, of course, we have to deal with this thing where they say, well, it's only for adults. But since nobody does studies in kids because it's hard and it's expensive and it's a pain in the butt, we just have to take adult drugs and start using them and kind of, I know it's not inspiring confidence, but when new drugs come out, that's typically what we have to do. What's nice with Banzel is it actually came out with the Lennox-Gastaut indication. We talked about that a little bit earlier, but it's a pediatric seizure syndrome with mixed seizure types, head drops, tonic seizures, atonic seizures, myoclonic seizures. So what was nice is this came out with an actual Lennox-Gastaut. The studies were done in kids with Lennox-Gastaut, and so that really, so that was really nice to actually have that to start with. It's a really pretty safe and easy to use drug. The main side effect that we have to watch for is loss of appetite, GI upset. So some kids can get really nauseous, just lose their appetite. That's one of the big deal breakers. But we don't see that often. And when it first came out, the recommendation was to go up to full dose within like 7 days or 10 days. So we don't quite get that crazy with it, but it's amazing you can go up on fast. So if there's seizures happening frequently, you can start it, you can go up quickly. And it can be helpful. We haven't had quite the luck that we've had with the other three that when I talk about my favorites, but it's one that I think really can be effective and does have a pretty good side effect profile. So this is definitely a promising one for Angelman syndrome, and it's one that I do use, and I'm not afraid to use it in kids with Angelman. I think it can be really helpful. Sometimes you get dizziness, you can get somnolence. There's really no blood monitoring needed. They recommend, when it first came out, they recommended EKGs, which is kind of tough, but really it can kind of prolong one of the waves on the EKG. But we definitely get those if there's a history of heart problems or in the family or in kids. But if not, it's usually pretty safe to start. The next one's Lacosamide or Vimpat, another one that's came out in 2011. But really in the last couple of years, it went from kind of, okay, these 4 or 5 don't work, maybe we'll try Vimpat. A lot of people using it first, using it second, so it's become big pediatric medicine. It comes IV, which is nice. So that's been used more and more just in the last few years. When it came out, it wasn't considered a broad spectrum, but it really is. The more we use it, the more we realize. So it would have been on that right-hand side, but again, it was the drug companies paid for studies to have it be an add-on medicine for adults with focal seizures. But the more it was kind of looked at, it really does help all types of seizures. And it can be really helpful when others fail. So similar to, so it doesn't have the GI side effects that Banzel might, but it can be fatiguing, not sedating like a benzo where you're drugged, but just tiring. So it can make kids tired, and we can see some dizziness or some imbalance, but those aren't common. Like I said, every drug has its thing. So if we see that, we stop it. But really, it's pretty safe and well tolerated. Same thing, it can do the same thing that Banzel can to the EKG. So if you're going to start both or have both on, we always get an EKG. Quick screening EKG just to be safe. And then it's the same thing like Keppra, you can start it and go up really fast. So if someone's in the hospital having a bunch of seizures, you can load IV Keppra, load IV Vimpat, and they're both safe, easy, and you can get the levels up really fast. So I think that's an up-and-coming medicine that people are using just in general in kids more and more. The adults use it a ton, but in kids now we're using it more and more and more. And I think it can be a good Angelman drug. And so Clobazam or ONFI, and it's Frisium in Canada, it's ONFI in the US, it's different things in other countries, but it's Clobazam, and it's an atypical benzo. So the benzodiazepines all have a certain chemical structure, and this one's a little bit different. It's that's what I call an atypical benzo, and the nerds that came up with it, it's the whole long name is 1,5 something 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 something, as opposed to the regular benzos, which are 1,4 something something. So because it's 1,5, that's why it's ONFI 1,5. So I told you it's pretty nerdy, but that's how they came up with the name. And the side effects, so like any benzo, it can cause drowsiness, it can cause sedation, can cause imbalance, can cause dizziness. But compared to being on Klonopin, Ativan, Valium every day, it's a lot less. It's not zero. We still see kids that get the typical benzo side effects, but it's much less common, and if it happens, it's usually much milder. It's really the one benzo family of medicines meant to be taken every day. We do give kids Klonopin. We can give kids every day, and it's not ideal, but we do it because because they need it. But it's a typical benzo that you get adjusted to, and you have to go up and up to get the same effects. Whereas ONFI, you get a little bit of that, but you don't get the same tolerance that you do to the typical benzo. So even though it has benzo-ish type effects and pluses and minuses, it's a little bit different. So it really is meant to be an everyday medicine, but it's not perfect. For the kids it works for, it's amazing. And I think I'll talk about it later, but one of the reasons I really like it is because it's a benzo, it can really help with anxiety, it can help with sleep. Some kids sleep amazing on it, some kids, their anxiety gets better. There's a small percentage of kids that get kind of manic on it, so so we stop it right away. So there's, like I said, there's no such thing as a perfect drug, and this is, even though this one's my favorite, it can make some kids worse, not seizure-wise, but behavior-wise, sleep-wise, whatever. So that's kind of how, when we pick medicines, that's what we do. We pick the medicine that we think is going to be the best based on how well it works, what the side effects are, what the other added benefits are. But even though we think about it a ton and use all this information and process it, it could be horrible because every kid's different. So we pick the best one that works, and if it does, great. And if it's not, then we go to our plan B and then plan C. And so it kind of seems like we're guessing sometimes, but they're educated guesses. We use all this information we have to pick the right ones, but the kids don't all read the textbook. So, if they're not going to respond to what they don't want to respond to. So really no routine monitoring, no blood, no EKG, anything like that. And like I said, it can be helpful for sleep and anxiety as well as seizures. So out of the other new drugs that came out, there's 3 really recently, just in the last year or 2. So one is Zogabine or Potiga. So there was some excitement when that came out. It's the first ever potassium channel blocker. Most drugs block either sodium or calcium channels, or they work on the GABA systems, or they do some other stuff. But this one's the first one that worked on potassium channels. So it came out. We used it on a few kids, some kind of mixed success. I didn't try it on anyone with Angelman, but then it came out not long after that it can turn your skin and your retinas blue, and that's probably irreversible. So we stopped using it. I don't think anybody uses it anymore. So it kind of had a short run. Luckily, none of our kids turned blue, but we try to avoid that in children, especially your retinas, because then you don't see after that. So the other 2. So the next one was eslicarbazepine or Aptium, which actually, in general, it seems to be a really good drug. For kids with Angelman, though, I worry because it's so Tegretol is carbamazepine, Trileptal is carbazepine, Trileptal is carbamazepine, and then what Aptium is carbamazepine, oxcarbazepine is Trileptal, and you can tell it's been a long morning. And then, but what Aptium is eslicarbazepine, so it's a new version of Tegretol and Trileptal, which we know can worsen things. It's the thought is that it may be more of a broad spectrum, but until that's known, I would avoid it in Angelman specifically. I do use it for actually a fair amount of the kids I see with classic autism, because they typically have multifocal seizures, and it's actually pretty safe and well tolerated. And it's once a day, which is nice, and it doesn't have a lot of side effects. But for Angelman specifically, until we get a better idea of whether it's a broad spectrum, I would be careful, because if it's really more like its predecessors, Tegretol and Trileptal, it can worsen things. So I would avoid it for now, but it's not. It's potentially could be something later. And the last one is perampanel or Fycompa. So Fycompa is an AMPA receptor inhibitor. So the 2 ways that medicines work on brain cells to fix seizures is the way an electrical impulse kind of goes through the brain cell is that things like sodium, potassium, calcium, they kind of come in and out of the cell. That generates this electricity, and it goes. So a lot of the drugs work on that to kind of quiet things down. The other thing is once a brain cell kind of gets that electricity and fires off, there's chemicals that make things excited and chemicals that make things quiet. So a lot of the drugs that we've talked about are GABA drugs. GABA is what quiets things, and GABA is what we think is the GABA genes in Angelman syndrome are one of the reasons why we see the seizures the way we do. But the other side of it is to quiet the excited stuff. So perampanel is an AMPA receptor blocker, so the whole AMPA thing those are the ones that excite. So it's kind of like Potiga. It's a new thing. It's the first of its kind. We don't think it turns anyone blue, which is good. The most similar, even though it's its own mechanism, as far as how it works, so far it seems kind of like Keppra. we used it in a few kids, and they had terrible behavior side effects, so I kind of didn't use it for a while. And then in a few other kids, not with Angelman, just in general, but then, with some other kids, there's nothing where really, let's try Fycompa, and had some really good results. So I think, that you get that anger, rage, just craziness in, we don't know how many kids. I think they reported about the same, about 20%. My guess is probably more like 50%. But since it's so safe otherwise, it's one of these medicines where if you don't have those anger side effects, it could be really helpful sometimes. So as a potential Angelman syndrome medicine, I think it's an option. There's others that we know have less side effects that we use first, but if several medicines don't work, I think that can be added to the list of potential medicines. So it's still new, we're still getting the hang of it, but it has a really long half-life, so it's only once a day. Start at a really low dose and go up, but that's also kind of a nice benefit. So looking at, so we talked about the older study that we did early on, looking at the survey, the Seizure survey, who's used what. So I mentioned this a little bit this morning at the adult talk, but looking at medicines used in our clinic, the medicines that were most commonly seen, and they're probably these medicines because those are the ones I use, most of them are Levetiracetam, which is Keppra, Lamotrigine, which is Lamictal, Clobazam, or ONFI, and Valproic acid, which is Depakote, which I don't actually start much because of the side effect profile, or probably not at all, actually. I don't really put kids on it unless we really have to. But what we see is, what we saw in the survey is that, they are, the Depakote and the newer medicines like Keppra, Lamictal, they are all pretty effective. So Depakote is, it's been around forever. It works. It definitely works. The other medicines work around as well. And what's interesting is you look at the amount of percent improved. We have numbers like 85, 86, so way higher than that 23 in the other slide. This is probably a little bit skewed because they were medicines added to other medicines, and I know, like, at least for us personally in clinic, we really stress sleeping better GI habits. Like, we kind of make sure everything is treated because the better the rest of the body is working. So our rates may be a little bit higher, but I think the actual just rate of these medicines working is going to be way higher than 23%. I think it's well over 50. But if it's 80%, that may be a little bit high. But I think that it's not as refractory as we think it is. It's just using the right meds, and we don't use stuff like Tegretol, trileptal medicines that we know make things worse. You're going to see better results. So really, all four medicines tend to help a lot. The other one on the list, which I'll talk about in a little bit, is the LGIT is a dietary therapy that we use. Had good luck with that one as well. What we see with Depakote, which I kind of mentioned before, is that out of the kids that we've seen, 66%, so about 2/3, had pretty significant side effects, mainly motor side effects. So we see the weight gain, we see the hormone stuff, we see the periods, the whole bit. But what in Angelman specifically, what we see is, as I mentioned, you take kids who have tremor and balance issues to start with, you add a medicine that's known to cause tremor and balance issues, and it's kind of a recipe for poor motor skills. So, but like I said, it's not everybody. We have people that are on Depakote and doing amazing, and so we don't mess with it. But the ones who aren't doing amazing, I'm pretty quick to change. So, like I was saying this morning, for those who were here, we actually have had kids, 8, 9, 10. The oldest was 14 that never walked, that actually walked when Depakote was stopped. So, it's not always that severe. It's usually more mild, but it can be so severe that it makes kids not walk. The reason we started kind of looking at that and thinking about it was when we did the seizure survey and asked for side effects. There were probably 5 to 10 families who had said, we started Depakote and he stopped walking. And I was like, nah, that can't be true. That must be. But it is. We've seen it. And it's just, I think it's an Angelman specific thing. I don't think Depakote does that to other people, but I think it's just, you take movement disorder and you take a drug that messes with movement, and you just have a recipe for problems. But like I said, it's not everybody. It's like anything that I'm talking about is not absolute. It's the trends. It's what we see mostly. But so 2/3 of kids side effects. The other third, they were fine, so we didn't mess with them. And that's always my big thing: is don't mess with success. If you're not seeing seizures, you're not seeing side effects, then that's what you want. The problem was the reason we took these kids off Depakote was because we were seeing side effects and they got better. But the ones that were on it that weren't having side effects, it's kind of a don't rock the boat thing. The bigger picture though is that out of all these medicines, and it's not, we know the older, phenobarb, Tegretol, those do. There's some thought that Depakote isn't great for the bones. So over time, especially in kids who aren't super ambulatory, which is what really helps strengthen the bones, and especially in women with all the hormone interactions. We do worry about osteoporosis as people get older. So even though we have adults who are on Depakote, they're doing well. You don't want to rock the boat. We have seen osteoporosis. We have seen kids who were on it for 15 years, 20 years, who all of a sudden their liver studies went up. They said, no, this is Depakote, and other doctors that they saw said, no, it's not Depakote. Stop the Depakote, and the liver enzymes normalize. So that risk of osteoporosis and osteopenia, it's there, and it's going to get worse with age, especially in women. And then that risk of liver stuff, you've been on it for 10 years, you've been on it for 15 years, liver's great. It's not always going to be great. You still have to check. It may always be great. You could be on it till you're 80 and do great, but in some people that will catch up to you. So in general, if things are great, we always start a conversation. Well, let's think about coming off Depakote at some point. Not now, but when you're ready. And then at some point, we think about coming off. Just long term, it's not my favorite. There's if you can be on a medicine that's not going to cause, even if you think that the chances of Depakote are 5%, if you can be on a medicine that's towards 0%, that kind of makes me sleep a little better knowing that. And then, so basically, the data is that looking at the seizure survey. What we found was that the newer meds like Keppra, Lamictal, ONFI were as good as Depakote and Klonopin and how they worked, but with less side effects. Clobazam was new to the picture, so that wasn't around when we did the survey, but we see that it works pretty much just as well. And if you look back, about a third of the kids had side effects. So even though it's my favorite, 3 out of 10 kids, we have to take them off because they're tired, they're off balance, they're moody, they're whatever. But the other 7 out of 10, I really like it. And then similar to the 2009 study, we saw side effects with Depakote, mainly tremor and motor issues. So kind of moving past the seizures themselves onto non-convulsive, I didn't write it out on top, but NCSE is non-convulsive status epilepticus. So a lot of people probably heard about it. What it is I mentioned this morning, it's not so much as a seizure as it is an epileptic encephalopathy, which sounds nerdy, but the difference is when you're having a prolonged seizure, you're either in an absent seizure that just doesn't stop, so you have that clear decreased alertness, or it's a convulsive seizure, or you're twitching. That's what we call status epilepticus. But non-convulsive status is where your EEG is just really just messy, just like spike. And since it's not causing clinical seizure symptoms, you don't see seizures per se, but what you see is when your EEG is like that, that's what I call an epileptic encephalopathy, is you see a decrease in everything. You see less eye contact, you see less communication, less social skills, less interaction, worsening balance, people kind of falling over. So you just think things kind of go downhill like that. And the main thing to remember with Angelman is that it's not a progressive disease. People don't regress and get worse. They shouldn't. So if kids are getting worse, there's a reason, and you have to figure that reason out. And so it can be poor sleep, it can be anxiety, it can be pain, it can be lots of things. But one of the things it can be is non-convulsive status. So whenever kids are kind of going backwards, always check in with your doctor and say something's not right, and then you try to figure out what it is. But you should always call it to someone's attention if it's just for a day. You don't get too excited because it could be a bad night's sleep, or they're cranky, or I know my girls do that. But if it's a pattern, then it's something that really needs to be looked at quick. So when we treat non-convulsive, so you look in the literature, how do you treat this? You'll find nothing. But this is kind of one of the benefits of having 170 kids with a rare disorder, is that we just treat with what we kind of know from the epilepsy world, and then as some stuff works better than others, we stick with it. And what we kind of settled on for non-convulsive status was Valium, and there's no magic. It just tends to work, and tends to work better than the other benzos. So when kids have any kid with epilepsy has an acute worsening of seizures, and you really need to quiet it down quick while the daily meds are kind of ramping up, we'll use Ativan, Valium, Klonopin. We'll use these kind of like 6-day, 10-day courses of benzos just to keep things quiet short term while stuff's building up. So we started using those protocols, but we just found out that Valium worked better than the others. And like I said, it's not for every kid, but we've had really good luck with it. And so kind of the typical is 0.3 to 0.5 mg per kilo. So we do it by weight and age, and then divide it into 2 doses. And what we do is we do big dose for 2 days, small dose for 2 days, small dose for 2 days. If that doesn't work, we repeat it, or we just spread it out. So it's big dose for 3 or 4 days, littler dose for 3 or 4 days. And so with benzos, you can have withdrawals. So the way to stop the withdrawal is that tapering course. If you just give kids, big dose of Valium for like 5, 6, 10 days, then stop it. You can get withdrawal seizure, you can get withdrawal crankiness. So that's why we start a big dose and kind of taper it. And that really helps to minimize withdrawal. So, and kind of the classic story is something happened, they were sick, they went to Disney, there's something that kind of threw them off, and then the non-convulsive started after that. There's often, not always, but often a trigger. So that's a clue if there's something that kind of happened beforehand. So this is something that, again, a lot of stuff we haven't published yet, but I have like 10 papers that need to be published. But this one that we just that we're still working on is, we've looked at 11 children that had non-convulsive status, and there's been others that we've seen that were mainly treated elsewhere. So we've kind of, we talked about it, but didn't actually prescribe the medicines. But even if you add the few more kids, it's probably 10% of our kids. So the number is, it says 50% of kids with Angelman, and some studies higher. But in our 170, we're probably 10, 15%. So my hope is that the reason we're seeing less isn't just luck, but that we're using the right medicines, and we're focusing on not just seizure meds, but sleep and anxiety and GI issues. And hopefully that as we get a better idea of how to treat Angelman in general, and really kind of focus on what we need to focus on, that rate will actually be a lot lower. That's my hope. But so about 10, 15% of our kids, as opposed to the typical 50%. Out of the 11 kids that we treated, we had success with the Valium for 10 out of 11 kids, and for 17 out of 19 episodes. So we've been really lucky that the Valium has worked for so many kids, and so that's why I want to publish it, so it can be out there so other people can read it. But the only one kid, we just had one little troublemaker who responded great the first time he had it. So actually, if you think about it that way, all 11 did respond at one point. But then the second time he had it, he didn't respond, ended up in the hospital. That was a mess, but we got him better, got him home. And then the third time he came in, we knew we were headed back to the ICU. So instead of trying the usual meds that didn't work, we tried prednisone. So when you think about epileptic encephalopathies in general, the high-dose Valium became the big treatment in the 90s, and it's been since then. That's really what's been used. But before that, it was prednisone, and it was steroids. And people always ask, why do steroids work? And the answer is we don't know, which also inspires confidence, I know, in everybody. But it does, and we think that definitely the anti-inflammatory response is a big thing. But so when you have an epileptic encephalopathy, when the benzos fail, which isn't common at all, but when they do, prednisone can be helpful. That's the old standby. It's got more side effects. We do big dose for a week and then kind of taper it down. In extreme cases, you can do a big dose for a month and then less every month for 6 months. But you really have to watch blood pressure, blood sugar, all that kind of fun stuff. So it's not ideal, but this little guy in a 6-week trial, he really responded well. So it's nice to know that we do have potentially backup options. I still have a few more. I can go a little bit over. It's okay. So the big thing that we like to do a lot is dietary therapy. So you can treat with meds, you can treat with diet. And the two main, there's others out there, but the two that we use, the two that are probably the most common, are ketogenic diet and the low glycemic index. So the ketogenic diet started in the 1920s. The whole point was that hundreds of years ago, ancient Greece, ancient Rome, those kinds of times, when people would have seizures, they would starve them. So they just wouldn't let them eat for a month, and the seizures would stop. So people don't like that now. We don't let us starve their kids for a month. So what happened was 100 years ago was that someone had the brilliant idea to say, well, when we starve, we burn our own body fat. So what if we just give kids nothing but fat? And it actually works. We don't know why it works, again, but it's whether it's the fat itself or the byproducts of the fat or other things. But keto is 90% fat. It's less than 10 grams of carbohydrates per day. So we have to be as specific as like getting like sugar-free toothpaste, like that hardcore cutting out carbs. It's not easy to do. Kids with G-tubes, it's really easy. Just change the formula. But that's why kids that don't have G-tubes, we typically start with a low glycemic. But it's a couple days in the hospital. Just we have to monitor labs really close for a couple days. Kind of like I mentioned with Zonegran and Topamax, having all that fat in your blood that will make you acidotic. It will drop your CO2. So we just put them on a buffer to start with. If they're on Topamax or Zonegran, we have to be really careful. But it can be done. But we just have to monitor. So the low glycemic treatment was actually started at Mass General. Before I got there, Heidi, our dietitian, and Elizabeth Teal is the doctor that we work with, who's still there, who's the first person to use this. It was meant for diabetes, but what it is when you're on the ketogenic diet and you're eating lots of fat and no carbs, your blood sugar is low and stable, and your insulin levels are nice and low and stable. And I think that metabolic stress being taken out is really good for the brain. And so that's where low glycemic came from. You're not actually burning just fat; you're eating carbs. You're burning some of the carbs, so you can get a little bit acidotic, but not so much. And so it's safer, it's easier. There's no inpatient stay. It's 40 to 60 grams of carbs per day, not less than 10. So you can actually go to a restaurant and get chicken and vegetables. You don't have to bring the scale and weigh everything. So it's if you look at the numbers, it may be a smidge less effective, but only a tiny bit less. So it's worth trying first, and then if need be, you can always convert to keto. And it's easier to do keto once you've done this first. It's a smoother transition from a bunch of carbs to keto. And then the early data that came out was that about 1/3 either not effective or not well tolerated. 1/3 was 50 to 90% reduction in seizures, and 1/3 had a 90% or more, including seizure-free. So, compared to any given medicine, you're going to see probably a 40% response rate, whereas with the dietary therapy, and these are mostly kids who have been refractory to meds, you're seeing at least a 60 to 70% response rate of more than 50% reduction. So, we think it's a better treatment than any individual medicine. It's hard to do. So, and you can't underestimate how hard it is to not give kids bread and pasta and cookies, and it's not an easy diet. But for those who can pull it off, it can be really successful. So we get baseline lab. Well, I think Sheila taught me into talking about this later, so I think I'm going to be talking about it this afternoon. But we get baseline labs. Electrolytes, liver functions, renal, vitamin D, calcium, just to kind of check, make sure everything's okay to start with. And then we check it a month, and we check every 3 to 4 months after that, just to make sure everything's okay. We try not to draw blood whenever possible, and so I don't check a lot of medicine levels just because I don't want to. I don't like blood draws, but for diet therapy, we pretty much have to, because you can see low vitamin D, low carnitine, low CO2, and those are all things that are easily fixable that can make life better. So we check those, and as we always say, should be done must be done under the supervision of a dietitian or physician. Eating healthier, eating lower glycemic foods, that's always something we recommend, but doing it hardcore and really getting the carbs under 60 calories, under 60 grams, you really need to have someone helping out, because you need to, if it was that easy, we wouldn't need Heidi. So you really need to keep an eye on the ratios, on the calories. If you lose weight, you're gonna, if you're not getting enough calories, you're gonna get worse. If you have the wrong ratio, you're gonna get worse. If your lab tests get all messed up, you're gonna get worse. So it's, eating healthy foods is always a plus. Doing this really hardcore, and you really need to have help to do it right, to do it safely. So what we did, because we had a few kids had been on the diet, so what we did was we started. We did a This is the only actual trial we've done, where we do the whole thing, where we do the pre-trial stuff, go through the trial, do the post-trial stuff. But we ended up enrolling 6 kids on the diet. This starting back in 2008. 4 of the 6 had a 90% or more seizure freedom. 1 was in the 50 to 90% range, and 1 was less than 50%. And then when we published the paper, we had a year of follow-up, and 5 had stayed on the diet, and all 5 actually were 90% or more seizure free. And what's amazing is that was 2008. They're all 5 are still on the diet. They're still with us. So I thought that was pretty cool. And then I had another slide for the other talk, but as of now, we've put probably over 20 kids with Angelman on the diet. We have good numbers for 12, and we're still seeing about a 75% response rate. So the question is, are we getting lucky? Is there something about Angelman syndrome that really is different? Dietary therapy works better. We want to try to find that out as time goes on. It's easy to say, well, maybe our dietitian's better, but that's not the case, because even though she's amazing, she's the dietitian that did the old data. So we're comparing her work now to her work then, which is very similar. So, doing the same diet with the same dietitian, we're seeing better numbers than the general epilepsy population. And so we don't know if it's just luck, or they're just really good parents, or I'm sure that's part of it. But why are these kids responding better than most? So that's what we're trying to figure out. But so far so good. I don't think we have any kids with this, but when when two or more medicines fail, you always think about other options. So that's when we start the diet conversation, unless somebody comes to us and says we want to do diet first, in which case we're happy to do it. And then, but after two medicines, you start thinking about diet and surgery. So resective surgery, where you go in and cut parts of the brain out, that's helpful for a lot of kids with epilepsy, not for kids with Angelman, because it's a genetic disorder, so the whole brain's affected. Cutting part of it out is not going to help. But the VNS is a little device that's implanted in the chest wall, and the scientific convention. And so it wraps around these two big nerves called the vagus nerves. They go from the brain down to the heart and lungs and gut. The right one mostly goes down, the left one mostly goes up. So it's always wrapped around the left nerve, and it sends a pulse to the brain, like an electrical pulse up the nerve that goes to the brain. And we can control over time. We make it bigger and bigger and bigger. We take the pulses and make them smaller and closer together. And in studies show that 25 to 60% have had a 50% or greater reduction. It's never curative. You're not going to be seizure free on the VNS, but some kids can have a dramatic response and really improve. So when medicines, so we always try to talk kids into diet first before VNS, but when meds and diet don't work, that's an option. Like I said, it's not meant to make people seizure free, but it can really cut into them. So that is a potential. And then just talking about, I should probably gathered from what I've been saying about my favorites, but I really think some of our favorites are ONFI, Keppra, Lamictal, and Dietary Therapy, and that's why those were on that slide, because we use them the most. But just over the years, the hundreds of kids we've seen, they just tend to work better. And we have our looking back, and of course our numbers are skewed because that's what we use. We have more people on them, but the reason we have more people on them is because that's what works. And the more kids you see, the more things you try, you just get a sense of what works and what doesn't. And this is just kind of what works for us. So I can't say it's an absolute for everybody, but in our experience with 170 kids, those are what tend to work well. And knock on wood, but we've actually had really good luck with seizures. Anxiety is different, sleep's a little different, but at least seizure-wise, we've done pretty well. The medicines that I think can also be helpful, so Topamax, Zonegran, Depakote, although you got to watch for the side effects. Zerontin only for absence. Zerontin's not really great for, I forgot to mention that one, I forgot to make a slide, but Zerontin or ethosuximide it's an older drug that's fantastic for absence seizures, but it's not really known to help the other types, drops and whatnot. It can maybe, but not really. So in Angelman syndrome, the best use for Zerontin is you've got, drops and absence and myoclonic. Everything gets better but the staring spells, and then that's when it can really be useful as a nice add-on medicine for absence. So it's a great absence medicine, but it's not great for the other. It doesn't make anything worse. It's just not as effective just by the mechanism it works on the thalamus and these circuits. So it's great for the absences, but not so much for the others. It can help a little, but it typically not. And then Klonopin or the other benzos, although daily Ativan, daily Valium, not really something that we recommend because your body gets used to it. And then the Banzel and Vimpat, which are newer. Fycompa promising. Aptium's maybe I wouldn't use it yet. I probably should I wouldn't put it under avoid, but I would. I'd be very careful with that because we don't know if it's going to be a broad spectrum or not. And then people are probably going to ask, I probably should have made a slide, but cannabidiol. So cannabinoids it's medical marijuana, and so basically there's two parts to marijuana. There's the THC, which is the part that people won't like to get it on the street for, and then there's the cannabinoids, which nobody really wants, but that's the part that actually helps with seizures. We have receptors that those bind to, and there actually is good data in animals, and now there's been some, there hasn't been any really well done human trials until now. There's one ongoing across the country in different sites for different disorders, but it's promising. And once the trials are done, the data comes out. I think it would be. I think it's going to be a good thing, but we can't say because we don't know. But there's optimism. That's the best thing I can say. Is we're optimistic it's going to be good. Is it going to be a good medicine for Angelman syndrome? We don't know. But I'd say I'm optimistic that it is. We can't say for sure. So people ask, should we do cannabinoids instead of Keppra? I don't know. We don't know. It may be. It could turn out that it's the greatest medicine ever for Angelman syndrome, and we don't know that yet. It could turn out to be awful. We don't know that yet. But just based on what we know, we think it's going to be good. We just don't know yet. And in general, side effects are pretty low. And the ones to avoid for everyday use: phenobarb, dilantin, tegretol, triloptil, like I talked about. Loaded in the ER for status. Those are fine. You do what you have to do, but we don't like to keep kids on those. And then I only have like 2 more slides left, and I'll have to sneak out. But treatment of myoclonus. So those of you who've been here, we've heard about the non-epileptic myoclonus, so I'll kind of skip through those. But the good news, bad news. The good news is that it's not seizures, so we don't see those cognitive declines, those regressions. But the bad news is that they are kind of tricky to treat, as opposed to those nice 80%, 85% numbers that we saw with these same medicines. We're seeing 30%, 20%. So, the Keppra is a great myoclonus medicine. The benzos, Clobazam, clonazepam, can be really good. So we often use those in combination. Others can be helpful. Depakote can be, Zonegran can be, Vimpat maybe. So there's other options. There's sporadic kind of case, well, not reports, but stories of CBD, the cannabinoids, may be helping this. So once that's approved in the U.S., that would be an interesting thing to try for these. So, but right now, that's kind of the best we have, and it's not fantastic. But like I had said with the seizures, I mean, it kind of holds true for this. The best thing we can do for these myoclonic episodes, which is the same thing, the best treatments I think we have for seizure is minimizing anxiety, minimizing GI issues, improving sleep. The better everything's working together, the easier it's going to be to fix the seizures. And I think that's something that really needs to be kind of looked at more, talked about more. But really, the better everything else is, the better the seizures are going to be. And it's not always the case. It doesn't make all the seizures go away. They're certainly still going to happen. But making everything else better is going to give these drugs a better chance of working and give you a better chance of being on 1 or 2 and not 5. And like our dietary therapy for kids that can do it, for families that can do it, you can be med-free or just on one medicine, so a lot of kids. So I think that's it, relatively on time. But that's our crowd again, and I probably have to go in a minute, but I'll be around, and like I said, I think I'm giving another question and answer type of thing later. But yeah, thanks. Is that good? Sheila said I'm doing something.
Thank you, Dr. Thibert. So we need to excuse him now because he's got another meeting to go to, but he will be around to visit with you later on. We've got a quick little break, and then I think Erin Sheldon is up next. Thanks, everybody.